Now we are looking at the cellular architecture of emphysema. Look at the slide. On the left, we have a healthy lung. It has intact walls, optimal surface area, and good elastic recoil. On the right, we have emphysema. The walls are destroyed, surface area is lost, and air gets trapped. But how do we get from left to right? The answer lies in the middle, the protease-antiprotease balance. It's a battle between the destructors, proteases, and the defenders, antiproteases. When tobacco smoke enters the picture, it tips the scale. It increases the load of destruction and decreases our defense. The result? Unchecked lung tissue destruction. This brings us to the core theory, the protease-antiprotease hypothesis. Definition of emphysema. Emphysema results from a chronic imbalance between the enzymes that break down tissue and inhibitors that stop them. Look at the seesaw. On one side, you see protease, which has destructive potential, and on the other side, you see antiprotease, which has protective potential. The stakes: it is a war between destruction and defense. If the protease side gets too heavy, you lose alveolar wall integrity and elastic recoil. The key concept here is pathology is often just a disruption of homeostasis. Let's meet the combatants. First, the villain, elastase. It is a protease, an enzyme that eats protein, and its role is to clean up debris and bacteria. It specifically breaks down elastase. Remember, elastin is the rubber band that lets your lungs snap back after a breath. Where does it come from? Neutrophils and macrophages. These are your own white blood cells. They carry this weapon to fight bacteria, but in emphysema, they turn it on you. Now meet the hero, alpha-1 antitrypsin, A1AT. It is an antiprotease. Its job is to inhibit elastase. It handcuffs the villain so he can't destroy the lung. It is made in the liver and travels through the blood to protect the lungs. It is an acute phase reactant. Its levels go up during inflammation. Let's look at the battlefield in a healthy person. Peacetime. Look at the scale. Elastase equals alpha-1 antitrypsin. The neutrophils release a little bit of elastase to clean up old tissue, and the A1AT immediately neutralizes it. The result is that lung tissue remains safe, the walls are intact. But then, the invasion. The patient starts smoking. Tobacco smoke does two things. Smoking delivers a double hit. First hit is increased attack, recruiting more crew. It irritates the lung lining and recruitment. The lung screams for help, calling in neutrophils. The smoke literally recruits the army of neutrophils into the lung. More neutrophils mean more elastase. Second hit is disabled defense. This is the sneaky part. Smoke contains free radicals or oxidants. These oxidants attack the hero A1AT. They oxidize a specific amino acid, methionine 358, on the A1AT molecule. The result is the hero is blind. He can no longer bind to elastase. So you have more villain and a blind hero. The outcome is inevitable. Destruction wins. Look at the scale now. It is completely tipped to the protease side. Elastase is running wild. It starts chewing up the elastic fibers in the alveolar walls. The result is the walls break down, the tiny air sacs merge into huge floppy sacs. This is emphysema. Now there is an exception. Some people get emphysema even without smoking. This genetic exception is alpha-1 antitrypsin deficiency. In these patients, the liver tries to make A1AT, but the protein is misfolded. PIZZ genotype. It gets stuck in the liver. The result is liver damage. Because the protein is stuck, it causes cirrhosis. And the second one is lung damage. Because no A1AT reaches the lung is defenseless against even normal amounts of elastase. Now, how do we tell them apart? Pattern recognition. The first one is centriacinar emphysema. The cause here is smoking, and the injury is at the respiratory bronchiole, the center. Why? Because the smoke hits the center of the acinus first. C for center, C for cigarettes. Second is panacinar emphysema. The cause is genetic deficiency, A1AT deficiency. Look at the diagram. The entire acinus from bronchiole to alveoli is destroyed. Why? Because the deficiency is in the blood. The whole lung unit is unprotected, not just where smoke lands. Pan means all. Let's wrap this up with the ultimate cheat sheet. Smoking induced, the mechanism is high protease plus oxidized defense. Location is upper lobes, smoke rises, and pattern is centri-acinar emphysema. Genetic or alpha-1 antitrypsin deficiency. Mechanism is there is no defense, liver is trapped. Location is lower lobes, more blood flow causes more elastase delivery in lower lobes. The pattern is pan-acinar emphysema.